And I am Sreeni EDAKHLON, and I'll be speaking on dry eye. I've selected this topic basically because dry eye is the most irritating of all complaints for the patient and also for the treating surgeon. See, this patient came to us during the start of this present COVID lockdown. He wanted cataract surgery in his left eye because he couldn't open the shop during the lockdown, and he wanted to get over with it before the lockdown is lifted. He was seen by my colleague, Dr. Revati, in our Kanangat hospital, and she saw that the patient had very severe dry eye with photophobia and filamentary keratitis, and the patient also had severe meibomian gland infection. And I had done cataract surgery in his right eye about 2 years back, and he had severe dry eye symptoms post-operative. So Dr. Revati started the patient on hot formulation, lubricated drops and gel, topical fluorometholone, and oral doxycycline. And even after treatment for about a week, there was no significant improvement. So she added tacrolimus ointment, 0.1% BD, and oral omega-3 fatty acids. And this was a look after about 30 days of treatment. Photophoby was still there, but it was decreased. Cornea staining had decreased, but still there. There was a very minimal TM meniscus, and Schremer and BUT both were less than 5. But this patient is still insisting on getting cataract surgery done. See, can we do cataract surgery now? See, I made a real mistake in the other eye of not treating the dry eye before going in with the cataract surgery. What I and the patient suffered for months together. And the second question is, did we make a mistake in the dry eye classification in the first place? See, there are basically two types of dry eyes, aqueous deficiency dry eye and evaporative dry eye. And when you look at the definition of dry eye by Deuce 2, you can see that there are two central spots here. There's tearfilm hyperosmolarity and ocular inflammation, and this is seen here. And in evaporative dry eye, what happens is there is increased evaporation of the tear film, so that the osmolarity of the tears increases, and it triggers that inflammation cascade. And most often it is caused by meibomian gland dysfunction. And in aqueous tear deficiency dry eye, there is reduced tear production, hyperosmolarity of the tears, and associated inflammation. Also, it is basically divided into Sjogren syndrome dry eye and non-Sjogren syndrome dry eye. To diagnose Sjogren syndrome, the patient should have dry eye, dry mouth, parotid gland enlargement, unexplained increase in dental caries, abnormal serological tests, and significantly low Schremer test and all. But why are we really concerned about Sjogren syndrome? Because it's strongly associated with malignancy, and Sjogrens can kill, but a dry eye can't. So if you make a mistake of missing Sjogren syndrome in a dry eye patient, it is a huge mistake. And did omega-3 fatty acids really help? Studies have shown that omega-3 fatty acids don't really help in the treatment of dry eye. And was it right to use tacrolimus? See, cyclosporin and tacrolimus are the two immunosuppressants that are most commonly used in topically in ophthalmology. And tacrolimus is 10 to 100 times more powerful than cyclosporin. It is used twice daily for at least 2 to 8 weeks, and no serious adverse effects have been reported with the topical ophthalmic use of tacrolimus. But there is one report of cancer and lymphoma with topical dermatological use of tacrolimus. Is there a role in topical cyclosporin in this case? So when you compare cyclosporin and tacrolimus, studies have shown that they have equal efficacy, and whatever minor ocular adverse effects are there, they are also comparable. So there is no point in adding cyclosporin here. Now, coming back to the question, can we do cataract surgery now? The signs and symptoms have significantly improved, but I would go ahead with cataract surgery only if the patient becomes asymptomatic, and the Schremer, Tibet, everything increases, get the systemic investigation done. And if the medical management doesn't work, go ahead with punctal occlusion and control everything and go ahead with cataract surgery. Why am I really bothered about cataract surgery? I mean, managing dry eye and cataract surgery, because dry eye is one of the main reasons for patient dissatisfaction for following cataract surgery. And this is my second patient. This is from my the other hospital, Talasheri. The surgery was done about 2 weeks back. On the first post-operative day, the patient had severe photophobia. There was epithelial defect, punctate epithelial erosion, and this actually is a picture after 1 week. You can see that there is severe anterior blepharitis, punctate staining is there, the meibomian gland dysfunction is there, severe dry is there. If my colleague who had posted this patient for cataract surgery had seen these, she would definitely not have posted this patient for cataract surgery. But so where was the mistake? See, the studies have shown that anterior blepharitis worsened significantly within a week of cataract surgery. So there might have been some subtle signs and symptoms of dry eye, which was not that very significant to delay cataract surgery. And after cataract surgery, these all got worsened. So how to avoid the mistake of missing out on dry eye preoperatively? See, you have to listen to the patient. If the patient complains of irritation, foreign body sensation, tearing, burning, mucus discharge, etc., you should ask the patient. You should consider drying that. You should ask the patient if it is worse on wakening up, then it suggests aqueous tear deficiency. And if it gets worsened as the day goes on, it suggests meibomian gland dysfunction. Ask about systemic medications, dry mouth, gum diseases, and also look for rosacea on the face and eyelids. See if the eyelids are floppy. Look at the lid margins. There is meibomian gland dysfunction, blepharitis, trichiasis. Look at the quality and number of the blinks of the patient. Look out for conjunctive calluses. On slit lamp examination, you should also evaluate tear film properly, the tear meniscus. Look out for cellular debris, mucin in the tear film. And if you suspect dry eye, do all this tests to confirm. So coming back to the treatment for this particular individual. So for the treatment, if you classify it in terms of severity, it falls into based on his signs and symptoms, it falls into level 3 of severe dry eye. And for level 3 dry eye, these are the treatments that are advised. Oral tetracycline, we are given oral doxycycline. Unpreserved tears, we have given that in place of cyclosporin. We given tacrolimus. So if it doesn't work, we'll have to go for punctoplex and autologous sera. So what about the second case? The post-operative case has got blepharitis and everything. So if you check the literature, you can see that eyelid hygiene before and after cataract surgery improved post-operative subjective symptoms and prevented post-operative exacerbation of anterior blepharitis and meibomian gland dysfunction. So warm compress was given to the patient. Lid hygiene was given. Lid cleaning was advised. Oral doxycycline was given. Antibiotic steroid ointment was given for application on the lid margin, and lubricating gel was given. So what about the post-operative medication? It's post-cataract surgery post-operative medications. I shifted from prednisolone acetate to dexamethasone. I'm not sure if everyone would agree to that. And what about the lubricating drops? See, we have a huge number of chemicals available in the market for managing as lubricating drops for managing dry eye. But my personal preference for such a severe dry eye with epithelial defect and all is Gendeed gel, which is 0.3% HPNC with sodium perborate. And that was what I gave. And what about topical NSAID, cycloplegics, and anti-glaucoma medications? See, if the patient had suspicion of high IOP, I would prefer oral Diamox instead of topical medications, because all these increase the dry eye. NSAIDs were stopped. And if at all,
all due respect, I expect you to just wrap up in the next.
No. This includes the interaction also. That's okay. Okay. So, and if at all irritation was there, I would stop. I mean, I would not give oral antihistaminics. And basically, this is it. And see, before I go to our next speaker, Dr. Kaushik, we have two of the best cornea specialists in India with us, Dr. J.K. Reddy and Dr. Vanati. Dr. Vanati, can you please advise us which type of tremor test would you prefer? One with anesthesia, without anesthesia?
Okay, I would do without anesthesia. And again, Shermer's test is not a very reliable or a very indicative test of the severity of the dry eye disease, except that you would really be able to assess the amount of aqueous tear secretion which is available in that particular patient. I always rely upon the test to look for the tear stability and for the ocular surface damage. These two directly corroborate with the severity of the disease, and the amount of conjunctival hyperemia also helps you to alert to the amount of ocular surface inflammation the patient has. So you first quantify the amount of discomfort the patient is having because of the dry eye disease. Second, you move on to your triaging questions and then identify the particular risk factors which causes the dry eye disease. Third, apply the relevant diagnostics. And fourth, you will move on to treatment modality depending upon the level of severity of the dry eye you are looking at.
And do you look for the tear breakup time?
Yes, I always do the tear breakup time and the ocular surface time.
That it is 10 seconds or 15 seconds. Is it?
You always keep a cutoff. Whenever it is below 10, then you're going to get alerted. And you would, again, depending on the severity, you might be seeing it as an instantaneous breakup. You could have 2, you could have 4. Anything below 10 is what is going to alert you that this is a patient who's going to need intervention modalities. And commonly with an evaporative dry eye disease, then that's
okay.
a different.
Okay, and JK sir, JK sir, what is your choice of lubricating drop? You have different choices for aqueous deficiency and evaporative dry eye, or what do you say?
There are many things given, like some for vision deficiency, some for this one. But what we found in my practice is the severe dry eye, I use thinner the drops. I don't use thick drops for severity, because the purpose of the thicker drops is retaining the aqueous available in the ocular surface. If there is a aqueous deficiency, not evaporation, and you apply a thicker drops like a 1% drop, it's going to mess up the condition. So I go for a thinner ones, 0.3%, like that. So if there is a aqueous evaporative component is more than the deficiency component, then I go for the thicker ones like 0.1% methyl cellulose. Remaining all, you have to try trial and error. Each person somehow they like one, so there is a lot of combinations available now. So that's.
And what about the topical steroids? What is your preference, like fluorometholone or lotiprednol? I mean, occasionally you have to use it.
The first preference is lotiprednol. That we can go for low strength. Then second preference is fluorometholone. Very rarely we go for dexamethasone once a day.
And do you use tacrolimus? Because I think you were one of the first persons to say, okay, this can be used. Do you still use that?
It does help. Yes.
So
yes.
You choice between tacrolimus and cyclosporin?
For mild cases, cyclosporin is good enough. Mild inflammation in the ocular surface. If there is severe inflammation, definitely you need tacrolimus. So cyclosporin is not enough.
And Dr. Vanity, like for oral use, would it be doxycycline or azithromycin for 3 days, then continue with doxycycline and meibomian gland dysfunction?
I always give a doxycycline because it's relatively safer, and when your age limit is permitting you to give, then for older children and adults, doxycycline 100 milligrams OD or BD for a long period of time. But when you do have an obvious meibomitis sitting out there and you have other lid adnexa problems, then a short course of azithromycin always helps as well.
And is there any specific preference for, there are a lot of solutions available in the market, any specific preference or
I think as Dr. JK rightly pointed out, most of them have a very similar viscosity index here. And when you're looking at aqueous replacement, you would like to use a low viscosity agent here, and you would not want it to be more viscous here. And
it's regarding the solution for cleaning the lid margin.
For cleaning solutions here, Preferably, we do have the combinations of, tea tree oils, or you have medicated wipes which are available for right now. But what works well is just do a good hot fermentation and a good lid massage to express out. And any of the simple antibiotic ointments also work well as lubricants when they are in a very active stage of inflammation. Maybe a mild steroid as well to control, and oral antibiotics. They work perfectly well. And over, looking at medicated wipes for cleaning the lid surface.